Hello and welcome to MIHOPE-Strong Start Evaluation webinar. I would like to introduce you to your first presenter and speaker for today, Ms. Molly O'Fallon from the National Service Office. Ms. O'Fallon, you have the floor.
Thank you very much. And thank you all for joining us here today. I work in the National Service Office and I coordinate various aspects of the MIHOPE program. This webinar is designed to discuss the MIHOPE-Strong Start Evaluation. The National Service Office and David Olds thank you for attending this webinar and your thoughtful consideration about participating in the evaluation at your agency and with your clients. This evaluation is an opportunity to support sustainability of our programs so that home visiting can continue for our clients and families. We understand the changes and the obligations that have occurred to all of our agencies over the last few years as a result of MIHOPE. The MIHOPE-Strong Start is an added activity, but it will provide us with an unprecedented opportunity to demonstrate successful outcomes in the NFP program during implementation as compared with the initial randomized controlled trials. Additionally, the information that will be gained will increase the possibility of long-term sustainability for clients and families through Medicaid funding. We received several questions about MIHOPE and MIHOPE-Strong Start, and we designed this webinar to address these questions. This slide sets the tone for our meeting. Regarding the MIHOPE-Strong Start evaluation, the federal government is interested in the feasibility of a structured method to cover home visitation using Medicaid. MIHOPE-Strong Start is a study that will evaluate the effects of home visiting on birth outcomes and improved health outcomes for moms and their newborns to determine the feasibility of Medicaid funding. MIHOPE-Strong Start needs your agency to participate to ensure a large sample size. And this presentation provides an overview of the study. There's quite a bit of other materials and activities that occur as you participate with the MIHOPE-Strong Start team, so look forward to that information after this meeting. The agendas for this webinar are, we're going to start with a summary of the MIHOPE-Strong Start evaluation, then have a comparison of MIHOPE and MIHOPE-Strong Start, provide you with some information about tools that have assisted agencies that are participating in this study. We want to provide an overview of some of the issues that have been identified from the participants, as well as some solutions that are being used in the field related to the evaluation. David is going to talk about random assignment and why that's important. And then we're lucky to have the perspective from an agency that's participating in MIHOPE. And finally, we'll end with questions. We ask that you submit your questions at the bottom, that you type your questions in to the chat box. Due to the number of participants, we won't be able to answer these verbally, but we will have time at the end to answer anything that's in the chat box. For this webinar, the speakers are Ginger Knox. Ginger is the co-project director of MIHOPE and MIHOPE-Strong Start for MDRC, which is the organization that's coordinating the study. David Olds. David is a professor of pediatrics and the director of the Prevention Research Center for Family and Children Health at the University of Colorado Department of Pediatrics. Margarita De Santos is a community health manager at Southern Nevada Health District Nurse Family Partnership Program. And she is joined by Mary Teresa Johnson, who is a senior community health nurse at the same NFP program. In addition to the speakers, there's 3 panelists that may participate in the question and answer section. That would include myself and also Sharon Rouser and Jill Filene. Sharon and Jill both work with the MIHOPE-Strong Start evaluation team, and some of you may already know both of them. I'd also like to let you know about those who have registered for this webinar and will be listening. At this time, we have 90 people that are participating, so we won't have time for everyone to identify themselves. Who we did want to let you know that is participating or is registered for this program are individuals from the Centers of Medicare and Medicaid Services, or CMS. We also have Nancy Margie, who's the federal officer from the Administration for Children and Families, Office of Planning and Research and Evaluation, We have various members from HRSA and ACF that are joining us. We also have several representatives from states that are implementing NFP, with McV funding. We have multiple and various staff members from agencies that are implementing NFP. And lastly, we have staff members from the National Service Office. I'd now like to go ahead and turn this over to Ginger Knox, the co-project director for MIHOPE and MIHOPE-Strong Start, and to remind you to put any questions that you have in the box. Thank you very much.
Thank you so much, Molly, and thanks to all of you for joining us today to learn about MIHOPE-Strong Start. A very special thanks to Dr. Olds as well and the NSO for hosting this discussion and for their support of the study. So as Molly said, my name is Ginger Knox, and I work for a nonprofit social policy research organization called MDRC. I'm one of the MIHOPE-Strong Start project directors. Some of you who may have already heard a little bit about MIHOPE-Strong Start, but then we know that others of you have not. So we're going to start this conversation today by providing a brief overview of the study in general, including the purpose and design of the evaluation, as well as the important role that NFP programs across the country will play in helping us to learn more about home visiting. So MIHOPE-Strong Start is an evaluation of current home visiting services, which is national in its scope. With the partnership of the Nurse Family Partnership and Healthy Families America programs, we'll be enrolling up to 15,000 women in the study with a goal of learning how the services that you're providing every day improve birth outcomes, maternal and infant health, and patterns of healthcare utilization. We know that it's a big effort to undertake a study with so many participants and local programs. So one of the things that Dr. Olds and I will be discussing today are the kinds of things that we'll be able to learn from this study that we have not been able to learn from prior studies that were smaller scale. MIHOPE-Strong Start is sponsored by a partnership of several offices at the U.S. Department of Health and Human Services. The study is part of the Center for Medicare and Medicaid Strong Start for Mothers and Newborns initiative, in which the center is looking at ways to reduce preterm births and improve outcomes for newborns and pregnant women. My colleagues and I at MDRC are part of a larger team that was selected by HHS to conduct the study. We're from 4 different organizations that are listed here on the slide. And the team collectively has extensive experience doing home visiting research, providing technical assistance to programs, and carrying out this type of large-scale random assignment evaluation. Some of the most important members of the study actually aren't listed here. In particular, we appreciate the partnership we've had with the NSO and with local NFP and HFA programs. And we're especially grateful to have the opportunity to work with families across the country who will be participating. Now, some of you may have heard of the MIHOPE study, or may even be part of the MIHOPE study, and if so, we really thank you for the great work that's going on so far in MIHOPE. MIHOPE is a national evaluation that's related to the MIHOPE-Strong Start study, and this slide gives a little comparison of the two so that you can see what is the same and different about them. So MIHOPE is studying the impact of 4 evidence-based home visiting models. It's a national evaluation that covers Early Head Start, Parents as Teachers, Healthy Families America, and the Nurse Family Partnership. It's going on right now, enrolling study participants and following up with them, and it's authorized by the McV program under the Affordable Care Act. Now, MIHOPE-Strong Start is what we're really here to focus on today. It's a companion study to MIHOPE, and it's going to expand what we can learn by including more states, programs, and clients. MIHOPE-Strong Start will include only Healthy Families America and Nurse Family Partnership programs, because those are the 2 evidence-based models that have shown some impact on birth outcomes in their prior research. Another difference is that local programs can participate in MIHOPE-Strong Start whether or not they are receiving McV funds, whereas in MIHOPE, all of the programs are receiving at least some McV funds. One other difference to point out that's not on the slide here is that MIHOPE-Strong Start will not collect as much new data as MIHOPE is collecting. So most of the data will be collected from existing records that your state or the program models already keep. For example, we'll be using automated MIS system data, Medicaid records, and vital records. We'll be doing a 20-minute survey with families when they enroll in the study, and then a one-time survey with program staff as well. But for example, if you've heard of the weekly logs that are being collected in MIHOPE for service delivery, or the videos that are being conducted of home visits, those are not going to be collected in the MIHOPE-Strong Start. So we want to talk a little bit about the evaluation and what its components. It has two main parts. One is about what impact home visiting has, and the other is about how home visiting is being implemented. The impact analysis asks, when we put information from this large group of local programs together, do we see evidence that the services you're providing are improving birth outcomes, maternal and infant health, and healthcare use? And how do those effects differ for families who come into the program with different kinds of risk factors? To measure the impacts, we'll be using a random assignment design, which means that some women will be assigned to receive home visiting services and some will not. This is very similar to the design that Dr. Olds has used in his prior research about NSP, and something we'll be discussing in a little bit more detail in a moment. In the implementation analysis, we want to learn how home visiting programs operate, who's participating in them, and how programs are achieving their impact. So we'll look at things like how many home visits families are getting, what programs are doing that might affect families' engagement, like the consistency of supervision for home visitors, or how well prepared the staff feel to work with different kinds of families on challenging issues that might affect birth outcomes, like smoking cessation or substance abuse. These are important questions, and they'll allow us to dig deep and learn not just whether home visiting is changing outcomes, but also how and why, so that we can really provide some concrete lessons to be even more helpful to families in the future. So we mentioned that MIHOPE-Strong Start is designed to use random assignment. And I know that many of you are familiar with random assignment because it's been used in home visiting studies and, of course, in other kinds of clinical and medical trials. But we do think it's important for you to understand why we're using it in this study and how we're thinking about it. As you probably know, random assignment is a process like picking names from a hat. It's sometimes used outside of research settings as a fair way to allocate resources when there are more people who need a service than program slots to serve them. For example, charter schools often use lotteries to decide who will be invited to attend them when they don't have enough spaces. As a research method, random assignment helps to estimate the average impact that a program has for the people that it's serving. So in this type of study, applicants to the program who are eligible for the program go through a lottery-like process that places them in either a group to receive program services or a comparison group. In MIHOPE-Strong Start, those in the program group would be enrolled into your home visiting services, while those in the comparison group would not enroll in home visiting services, but they can access other services in the community. The differences between program group and the comparison group that emerge over time can be attributed to the program services. The importance of random assignment is that it eliminates questions about whether the differences that we find later between the two groups might have actually been caused by differences in their characteristics that were there from the beginning. So since the comparison group and the program group were created randomly, it means we know that the group started out with very similar characteristics, similar motivation and interest in the program, with the only difference being that one group ended up enrolling in the program and one did not. So for this reason, random assignment is widely accepted as the most reliable way to measure program effects. It's important also to note that it does not result in fewer people being served by a local program. As long as there are more people eligible in the community, then the program is able to serve. So now we've talked a little bit about the basic design of the evaluation, and we want to talk about now some of the specific roles and responsibilities that participating organizations would have in MIHOPE-Strong Start. We're approaching states where it seems possible that we could enlist a number of local programs to participate in the study so that we can reach our large sample size. And the reason that you all are part of this webinar is that you're a program that the NSO has suggested may be a strong candidate for the study. So what will local programs actually need to do if they do enroll in the study? The local program plays a role in enrolling clients into MIHOPE-Strong Start using information and resources that will be provided by the study team. And then with your help, we would be randomly assigning your incoming eligible clients through about September of 2015. And we'll ask your staff to participate in a one-time survey themselves about how they approach their jobs. Each study site will be working with members of our study team to think through how many people in your site are likely to enroll into the study so that we can customize the study intake process so that it fits best into your local intake process, and also to decide when would be most convenient to start enrolling into the study. We're going to talk about some different supports that are provided by the research team so that the study will take as little of your staff time as possible. And one of those supports is a video that we're going to show you right now. It would be used by staff who are talking to potential enrollees about the study so that they can put on this video and let it provide an initial overview of the study to the potential client. Then they would talk a little more with the client to make sure that they understand what the study entails before the client decides whether to enroll in the study. So Gerald is going to just play this video for us, and then we'll continue after that.
All over the country, home visiting programs are taking part in something special, the MIHOPE-Strong Start study. The study is designed to learn how to best support the health and well-being of families. Led by the U.S. Department of Health and Human Services, MIHOPE-Strong Start will include up to 15,000 pregnant women across America. A nonprofit organization called MDRC is conducting the study, along with Mathematica policy research and other researchers. Studies such as MIHOPE-Strong Start have helped home visiting programs make a positive, long-lasting difference in people's lives. This video explains what it means to be a part of MIHOPE-Strong Start. So, now that you've heard more about the home visiting program, what do you think?
Well, it sounds like something I might like. When I first heard about it, I wasn't sure. But then I kept thinking about my friend Jessica after she had her baby girl. I think it might be good if I had someone to ask questions to while I was pregnant. And after, when my baby is finally here.
Oh, great. We'd love for you to participate if there's an opening. Before we find that out, I want to see if you'd also like to be part of something called MIHOPE-Strong Start.
I don't know. I don't think I can handle anything else. I've got a lot of people counting on me and a little one on the way. I really need to step up, you know?
Well, I think it just might be a way for you to do that. MIHOPE-Strong Start is a national study about home visiting, and an opportunity for you to help other families like yours by sharing your experience. It's a small commitment, but if you participate, you could make a big difference. Programs like mine have to make difficult decisions about what services to offer. There's been a lot of research on how home visiting helps families, and studies like these have helped answer important questions. This study can even help to change Medicaid and other health insurance so more families can get home visiting.
So, how does the study work?
Well, to begin with, you can sign up for the study because you're enrolled in Medicaid or CHIP and have at least 8 weeks until your due date. This is a consent form. We can review this form together. It describes what it means to be in the study, and if it sounds good to you, then you can sign up at the bottom. After you sign the form, we'll call a member of the MIHOPE-Strong Start research team together. They'll ask you some questions about your background and your health and other personal questions. They understand if you don't want to answer all the questions. You don't have to answer any that make you feel uncomfortable. The questions should take about 20 minutes, and because the researchers really appreciate your time, you'll get a $10 gift card in the mail to say thanks. After you give birth, the research team will gather information about you and your baby. For example, they'll reach out to request the baby's name, social security number, date of birth, and Medicaid number after she's born. You'd get a $5 gift card for returning that information.
I don't know. That's like a lot of personal information.
It is, but that's why the researchers have special ways of handling it. The research team follows strict rules to keep your information private.
Okay.
They're also going to ask you for the names of 2 people who might know how to get in touch with you later.
Why do they need that?
It's just in case you move and they have trouble reaching you after the baby's born.
But how do I know if I'm going to get home visiting services?
Great question. Everyone we're talking to about the study has an equal chance of getting into our home visiting program. The study doesn't change that. The odds are still 50-50.
But how does that work? Who picks who gets in and who doesn't?
To be fair, our home visiting program chooses who to serve randomly, like tossing a coin. Heads you enroll in home visiting, tails you get other community services. It's all done by a computer. Every woman gets the same chance.
Well, what if I don't get picked for home visiting?
You would still be in the MIHOPE-Strong Start study and get the gift cards, and I would give you a list of other places you could go to for services.
Okay, let me make sure I'm understanding all of this. So, no matter what, I have a 50-50 chance of being enrolled in the home visiting program.
Yep.
And if I give my consent and join the study, all I have to do is answer a few questions about me and my baby, and I get 2 gift cards.
You got it.
But how does that really make a difference?
By making these programs the best they can be. We need studies to make sure we're giving new moms and their babies the best kind of help. It's people like you who participate in the studies that make it work. What you decide to do today can make a difference not just for you and your baby, but for families across the whole country for years to come.
Well, my baby has got me thinking a lot about the future, and the kind of future I want her to grow up in. I think it's time for me to step up.
Hello again. I just want to mention that I think some of us had some buffering issues during the video, and the way that the video will actually work out in the field is that we'll be giving local programs DVD players so that you won't be relying on the internet to play the video. So that'll help with that. So that was just one of the tools that the research team provides to local programs to help as they're talking to potential clients about the study. And then there's some other things the research team will be doing to partner with you along the way. So as I said a moment ago, we will be providing some flexible funds to all the programs who participate in MIHOPE-Strong Start, which will support your activities in the study, as well as providing small gift cards to participating families in appreciation of the time that they're sharing with us when they enroll. We also know that sites need a steady flow of enrollees for this to work, so if needed, we'll work with you on recruitment strategies, drawing on our experience working with home visiting programs around the country. And together with that, we'll also help you communicate with your key local stakeholders and community partners about the study. So we have resources and materials that can help you in working with community partners to explain the importance of the study. And we're also happy to personally join in meetings and discussions if you think that that would be helpful. We also provide detailed training and support to the local home visiting staff on all of the research procedures. So all of those things are our job to take care of. And finally, of course, we would be collecting and analyzing the data, writing up the results, and disseminating the findings from the evaluation to both the policy community and to practitioners and program operators. So I'm just going to wrap up before handing it over. to Dr. Olds with a few last thoughts about why your site would want to participate in this kind of study. So as a result of the seminal work of Dr. Olds and others, we do already know something about what works in home visiting, but still it's important to continue to reflect on current practices and try to address the unanswered questions that I mentioned earlier about what works best for whom and why. If you think of each previous study as a building block, each new study is adding to the growing evidence base about home visiting so that we're offering future families the most effective services possible. That's what motivates all of us, whether we're researchers or operating programs. And finally, as Molly mentioned, one very exciting aspect of the study is that the findings will be shared directly with the agency who sets Medicaid reimbursement criteria, which is the sponsor of the study. And as lessons are shared about the impacts of home visiting, the results may be used to inform future reimbursement criteria. So while there are no guarantees about that, it could potentially result in increased access to these services for expectant women across the country in the future. So we're really excited about this study as well as the possibility of working with each of you. And thank you again for your time. With that, I'd like to turn it over to Dr. Olds, who will be providing you with some of his thoughts about MIHOPE-Strong Start.
So thank you, Ginger, and thank you all for attending this webinar. I'd like to start by simply addressing a question that I think is on the minds of many of the participants, and that is, what are the ethics of conducting a random assignment study with a program that already has very strong evidentiary foundations? I think the key is to addressing this issue is really twofold. First, in the U.S. and in many local communities, we're only serving a very small fraction of the participants who might be eligible for this program. And in that context, random assignment is in my view, an ethical way of allocating a scarce resource. And the related issue is that if the program is found to be effective in improving outcomes in an independently conducted randomized controlled trial, it will lay a much stronger foundation for expansion of this program throughout the U.S. and in your local communities. So I think that the ethics are, in fact, solid in moving forward with this kind of work. As you know, the NFP has very strong evidentiary foundations, but questions inevitably remain about the degree to which the program can retain its impact when it's replicated in a variety of community settings. We, over the years, have taken great pains to make sure that the NFP is well developed in community replication sites, so that we're confident the program is on the right track. But until we have results from an independently conducted randomized controlled trial in community replication sites, we simply won't know for sure. And there will be people who will question the degree to which findings from trials that were conducted much earlier, trials that were conducted by someone who was aligned with the program, could apply in a broad policy context in today's environment. So, I've taken the position that we really have a responsibility, a collective responsibility to put this program to a really rigorous test in community replication sites around the country. If the program produces the kinds of results that all of us hope for and believe that it will, then we will be in a much, much stronger position to make a case for further expansion of the NFP and to use Medicaid as a source of funding for it. There's another important issue having to do with knowing about NFP impacts, and that is, to what degree does it affect preterm delivery and newborn health? Because the trials that have been conducted with the NFP so far have been too small to detect important outcomes on these types of effects on these types of outcomes, we're really uncertain about the degree to which the program affects preterm delivery and newborn health. Very large samples to be able to say with certainty whether the program is really affecting these really important health outcomes. And again, if the program affects preterm delivery and newborn health, we'll be in a very much stronger position to advocate for expanded funding for the NFP. And the other piece is that this study will create an opportunity to do really rigorous studies of the extent to which the program reduces healthcare encounters for injuries and ingestions, and especially hospitalizations for injuries and ingestions in the first year of life. And it will have large numbers with good outcomes with good measurement of these outcomes. There are some people who would argue that you don't really need to use random assignment for the evaluation of big programs like this that are being scaled up and spread out. And I really don't believe that's right. Anything short of randomization is likely to give us the wrong answer. The NFP has a history, a reputation for having been based on the very highest scientific standards. And I think that we collectively need to continue to support work that's based on these same standards of evidence, and when this work is conducted by independent investigators. I think that we need to get as many NFP sites to participate in this study as possible, because larger numbers will mean that we'll have a greater likelihood of being able to detect real NFP impact. If we have too few participants, we will not be able to detect modest or small effects that nevertheless may be really important from the standpoint of the U.S. domestic policy agenda, and that may have big impacts on cost. The larger the number of sites and participants, the greater the scientific integrity of the study. So, in my view, participation is both ethical and it's a really important part of a larger strategy to expand the program, to lead this field of work in the 21st century. So I'm happy to take later on particular questions that others may have. So thank you. I'm trying to get back to you, Ginger and Molly.
Yes, thanks, David. So we have a couple of things left before we respond to questions. One is that there are a couple of questions that have come up, in several different conversations we've had with local programs that we wanted to just go ahead and address while we're all here together. And I'm going to talk about those, and then we'll be hearing from Margarita de Santos about their experience in the MIHOPE study. So first of all, I just wanted to respond to a concern that we've heard about that the staff in the local programs will be the ones to enroll potential clients into the study. And, people are concerned that this could be disruptive by taking them away from the other work that they need to do, and that it will require some training about the study, and people are just wondering sort of how that will all work. So the main thing to be aware of really here is that we're very flexible on how we set up the study in each site. And so we do a lot of one-on-one work. We do need the local staff to do this consent process into the study, since you're the ones who have the direct access to the clients. But who does this activity can vary from site to site. So some sites might use administrative staff, others would use their nurse home visitors, supervisors, or other people who might be available to do that in your particular site. So the liaison from the study who would be working with your individual site could help you think creatively about who might be able to take on this role. So each site does have an experienced team from the study who would work with you throughout the process to design something that will work well in your program. And then the same folks will come and train your staff when it's time to start up the study, and will support them throughout the study as questions come up. As I mentioned, also we'll provide some resources to help with the study enrollment process. So we have flexible payments for each program to offset staff costs as much as we can, which amount to $5,000 up front, plus depending on how many families you plan to enroll into the study, it would be another $10,000 for every 100 families that you think you can enroll. So it's enough funds that should be able to offset some of the staff time needed to enroll people into the study. And that is how sites often end up using those funds. It also offsets costs like attending the one-day training that's at the beginning of the study. But it can be used for whatever a site thinks would be helpful to them. The second concern we've heard, besides the ethics of random assignment, as David addressed, is just how random assignment will work in an individual program, and whether it means that programs will have a harder time filling their program slots. For example, some sites have said they're in the middle of an expansion of their program, while others are just concerned that because they don't keep waiting lists, they're really not sure if they'd be able to do the random assignment and keep bringing in enough people to fill their slots. And one issue there is that some local managers have talked about funders' expectations for keeping slots filled, and they really, needed some help thinking about how that would work during random assignment. So we do understand these concerns. We know that your staff work really hard at bringing families in and maintaining partnerships in the community for recruitment. And sometimes before starting a random assignment study, it can feel uncertain how that will go once you begin random assignment. So there are a few things, there's a few ways we think about this. One is that both HHS and our study team are committed to making sure the study does not result in fewer families being served. We don't just come into your site and ask that every site do this a particular way or bring in an exact number of families, sort of regardless of your enrollment patterns. We work with you to come up with a target number of families that's reasonable given the way that your recruitment works and your flow over time. So it really is tailored to each program's circumstances. And then because we do this tailoring, what we've found in the MIHOPE study, which uses a very similar random assignment process, is that even programs that expressed some of these concerns before they started have actually found they are able to keep their slots filled. And one reason is that in the process of working the study into your intake process, what happens is that your recruitment and intake process often gets some extra attention. And our staff give advice along the way based on your circumstances that can help address any bottlenecks in the process, might help you identify some new sources for referral if that's a need. And we have some ideas based on what's worked well in other sites. So what we've actually seen in MIHOPE is that the NFP sites, 85 to 90% of the NFP sites are actually ahead of schedule in terms of bringing in clients into the study and enrolling relative to what we projected with them at the beginning. So they're doing very, very well in bringing in study enrollees and keeping their slots filled. And a third point is we do know that some sites are in the process right now of expanding or have other special concerns about filling their slots. So one thing that we did recently that some of you may be aware of and others may not, we've actually made a change in the study design for MIHOPE-Strong Start in which we've decided to include more people in the program group than in the comparison group. So instead of having a 50-50 chance of being in each group, there's actually going to be a 60% chance of being in the program group and getting home visiting services and a 40% chance of being in the comparison group. This was really, honestly, partly in response to concerns about programs in the middle of expansion and really wanting to be sure they could keep their slots full. And so just a few days ago, we got approval from HHS to make this change. So I think actually at this point it's important that you hear from some of your colleagues about their experiences in one of these kinds of studies in an NFP program. So I'm going to turn it over to Margarita to continue.
Thank you, Ginger. Margarita de Santos. I'm the Community Health Nurse Manager with the Southern Nevada Health District, and I manage the Nurse Family Partnership Program down here. We were lucky enough to get some McVie funding to be able to fund a couple of additional nursing positions in our NFP program. Then Nevada was selected as a potential state to participate in the MIHOPE study. Nevada agreed to participate, so by default, we actually were also pulled into the MIHOPE study. There are 2 programs in Nevada participating in MIHOPE. There is Early Head Start home-based program in the north and in the south. And in Southern Nevada, it's also us, the NFP program. And I did want to mention that we did take on MIHOPE with an expansion, and we actually doubled the size of our team at about the time that MIHOPE came on. Not only as a result of some of the additional McVie funding, but also because our Board of Health was so impressed with the results that our team was getting in terms of outcomes that they allowed us to add even more nurses. We again also decided to participate as part of the funding, and we have had a tremendous amount of support for this and for NFP itself from our administration. And we felt that participating was very important because we feel that home visiting, as it is a benefit to our families, and feel strongly that home visiting needs to continue and to expand. It's just so important to our community. And then in terms of some of the randomization and concerns about maintaining caseload, when we first came on, we did have some concerns about the fact that we thought some of our referrals would be cut in half because half were being sent to another group versus the intervention group. But now that we have reached our goal and we are no longer doing that, we found that indeed that was not the case. I mean, there has been no difference since we've stopped enrolling for the MIHOPE program. A lot of that had to do with the fact that the key person that introduced the research study to potential participants was our team leader, Teresa, whom you will hear from shortly. And she did just such a wonderful job of explaining the program that I think we were successful because of that. Before we even started, just wanted to mention that there were several planning teleconferences, and the MIHOPE team was incredibly flexible. They allowed us to tailor the study to meet our program operations, so it went very, very well. We did present the study to our NFP advisory board, and our biggest referral sources, our biggest partners, are actually members of our advisory board. They had also expressed some concerns about the randomization, but we were able to arrange a teleconference with MIHOPE staff during one of our Board of Health meetings in which they were able to answer some of the concerns posed by our advisory board members. We had some initial surveys to complete that were about an hour long. Field staff have had others, and Teresa will discuss this a little bit further. We continue to provide updates during our quarterly advisory board meetings, and they have been pleased with what's been going on. We did have a 6-hour in-person training for the NFP staff on MIHOPE. This included topics such as what their roles were, how the study would flow, and how to enter necessary data. Staff were also given a resource notebook or resource notebooks. They each have one that they can refer to as needed. We've just had a tremendous amount of support from the MIHOPE team. We continue with our monthly teleconferences with the MIHOPE staff, in which we provide updates in terms of how things are going, and they are also able to answer any questions that we may have in terms of, the implementation. And we are currently in the process of discussing participation in MIHOPE-Strong Start as well. So we're looking at taking that on as well. And Teresa, I'll turn it over to you if you have some more comments.
My name is Teresa Johnson, and I'm the Nurse Family Partnership Supervisor here at Southern Nevada Health District. And I'll start with our kickoff. We had our kickoff the first week of April. This is when the MIHOPE team came to us and talked to us about the study, and we also had computer system training, and this is also when they answered most of our questions. And after the kickoff, we did a survey, which it took me like at least a couple of hours, and we received gift cards for our time and effort. And after the survey, this is when it really became real to us that we are participating in the MIHOPE study, that we really need to be focused and we need more referrals, or at least maintain the number of referrals that we receive every month to be able to recruit the 60 families that we need for the study. So I talked to our referral sources, gave them the information about the MIHOPE study, asked them for more support and send us as many referrals that they can send to us, and also inform them that not all the clients that they're going to refer to us will be in the Nurse Family Partnership Program. And they understood that, and they were very supportive. I also contacted other community resources that may possibly generate referrals for our program. And so the referrals came like they normally did, and then I checked them for their eligibility, and I know that I need to prioritize. Sometimes I have to make 2 phone calls a day to be able to get hold of them, or sometimes even several times to be able to reach them. And you know, we have population here in Nevada that phones get disconnected and minutes get lost really very quickly, and they move very quickly too. So I know that I need to contact them as soon as I can. And then when I talk to them and I explain to them the program, most of them are really, it's not a problem. They are willing to participate in the study, and they're really very enthusiastic to be part of the Nurse Family Partnership Program. But of course, there are some that are really a little bit reluctant when I talk about the study. First, they don't want to take the chance of maybe not getting the Nurse Family Partnership services. And also, this might be just their first experience to be part of the study, so they were a little bit hesitant. So those are the ones that required a little bit more work. I have to explain to them the study a little bit more, what it entails, and also emphasize that with their time and effort, that they will be receiving a gift card. And so, then if they said yes, I will participate, we put their names into the web-based system that the MIHOPE trained us to do. And with the MIHOPE, we have the research field assistant that comes and contacts the client and consent them in the study. And then after they've been consented and been seen by the MIHOPE team, then every morning, it's just like Christmas to me. That's the first thing I check in the morning, whether they've been randomized already, whether they are in the non-home visiting group or home visiting group. If they are in the home visiting group, then we just proceed to our regular enrollment procedure. And if they are selected to be in the non-home visiting group, we send them a letter letting them know that they were not selected in the home visiting group, and then we provide them a list of community services, prenatal providers that they can access. So, and right now, even after we finished recruiting our 60 clients, which took us six months and 2 weeks, we were able to recruit the 60 clients. And we still are checking our referrals for duplication. The MIHOPE team has really been very supportive and very accessible by phone or by email anytime we have any questions or concerns. And the web-based system, the computer system, is really very user-friendly. If I can do it, you guys can do it too. It's really very easy. So overall, it's been a very positive experience for us. We're ready to start with the MIHOPE-Strong Start.
One of the things I did want to mention is that we came to realize that we were already, in a way, randomizing referrals even before participating in the MIHOPE study, and that is because we are one team. We're not several teams, and we serve a community of almost 2 million residents. So there's no way that one team can serve, that level of a population. So what we do is we serve target zip codes, areas identified as areas of need by, the state health department as well as a United Way. And those families that that don't meet the criteria, don't reside in those zip codes when they're referred into us, then we would have to refer out to other community resources, including our generalized MCH home visiting team. So we came to realize that we were already kind of randomizing already. As Teresa says, it has been a very positive experience for us. We feel very, very strongly about participating in these studies because we really value home visiting programs, especially nurse-family partnership, and we want to be able to continue these programs, to sustain them, as well as expand them. Like many of you probably see the need in your communities as well. Anything else, Teresa?
I think that's it.
Okay, well, thank you. So now we're going to turn it back to Jill, who is going to moderate some questions and answers.
Hi, thank you, Margarita and Teresa, and to all of our speakers today. At this point, we're going to turn to the questions that we received through the Q&A panel. As a reminder, if you would like to submit a question, you can do so on the bottom right-hand corner of the screen. We have gotten several questions about whether the slides or the recording will be available after the webinar, and the answer to that is yes. We will have that available on our MIHOPE-Strong Start website within the next week or so. So we have gotten a lot of questions, and just wanted to point out that we won't be able to answer all of the questions in depth, but we'd be happy to keep talking one-on-one to respond to those questions when we meet with your team. So what I will do is I will read questions that appeared in the Q&A box and then give the panelists an opportunity to respond to them. So our first question is, enrollment prior to 29 weeks is part of our fidelity monitoring. How does the NSO plan to make allowances for this fidelity measure for sites that will be enrolling clients up to 32 weeks?
So this is Ginger. I can respond to that. So that's a great question, and it shows we weren't entirely clear by what we meant about the study criteria. So it's true that the study criteria are that someone can be within 8 weeks of their due date, but that does not override your program's eligibility criteria. So you would keep using your 29 weeks, and that sample would be eligible for the study because they're even earlier than the 32 weeks. So it means essentially the 32-week cutoff applies more to Healthy Families programs because they bring in families after that point and even after they've had a baby. So we're really using that cutoff in particular for those programs.
Okay, great. Next question. In most cases, there wouldn't be a 50-50 chance that the person would be enrolled in home visiting. Anyone who qualifies would be enrolled. So how would you address the fact that you had engaged them to enroll in home visiting and then tell them they may not get into the program they would have been enrolled in otherwise? Can you speak to how that would work?
I think that the way we think about that is that we would make sure that one of the things we train staff on who are talking to clients is to be careful that they're not guaranteeing the person that they would be in the program from the outset. And so the same way as when a community partner might refer someone now, they might not say that they're guaranteed a slot in your program because it's up to you to decide whether the person is eligible and whether you have a slot for them. And so in the same way, we would be training the staff to make sure that when they meet with someone who's interested in the program, they would say, we're going to have to, decide whether there's a slot or not, and we'll be getting back to you, because it is important not to mislead anyone or make them think they absolutely have a spot when they might not have a spot.
Okay, great. Next question. Would this study need to be reviewed by the local agency IRB, or is this being addressed by the National Service Office?
Do you want me to answer that, Jill? I'm sorry.
Sure. Sure. Go ahead.
This is Sharon Rouser speaking. I wasn't one of the presenters, but I'm part of the team that's meeting with local programs and explaining the study. And one of the questions that we ask whenever we're meeting with programs, and even when we're talking to people at a state or regional level, is are there IRBs that oversee the operations of your program services? And so we take the responsibility in the case where there are IRBs to connect with that, with the IRB. This is an institutional review board, if people don't know what an IRB is. And it typically they exist to oversee, ensure that the ethical treatment of people who are involved in research. And so we see it as our responsibility to interact with those IRBs, to follow whatever the procedures are for getting the clearance. And often it's things like they look at our consent form, and different states or different localities may have different ways that they want things phrased, and so they want our material to conform to that. And so we did that in MIHOPE whenever it was necessary, and we're planning to do that in MIHOPE-Strong Start as well.
And Joe,
there's one other point on that too, which is just that MDRC also has an IRB which has reviewed all of the study material. And so if a local IRB also wants to review it, that's their prerogative, but it has already been through one of those reviews.
And this is Molly. I'd just like to add one other thing. When all the information came out about MIHOPE and MIHOPE-Strong Start in the Federal Register notification, NFP did respond through our RAPCOM process, reviewed all the materials. The TRC and David's group also was involved, and we have formal letters that we sent around each aspect of MIHOPE and MIHOPE-Strong Start. Thank you.
Okay, next question. Can you talk about what kinds of services programs are allowed to refer families to that are assigned to the comparison group? Are they allowed to be referred to other evidence-based programs or other home visiting programs that are outside of NFP?
Do you want me to respond to that one, Ginger?
Sure.
This is Sharon again. So we really one of the things that Margarita and Teresa mentioned is the way that they worked with a team from our study to respond to issues. And so there's some things that we work locally with. And so with each program in the study, we work with them to create a list of the referrals that would be the people assigned to the non-home visiting group would be eligible for. And so it varies a lot the way these lists are developed. In some places where there's lots of resources, they're referred to 211. And some places it's just a few programs. It really it depends on the local context. I would say the issue about other evidence-based models is the programs, the list that you develop, it should be similar to the list that you already may be giving to clients who maybe are applying to your programs when you don't have an available slot, or maybe they're past the pregnancy cutoff, so they're not eligible for your program. So I don't think that the list would be very different.
This is Teresa, and when we send a letter to our clients and inform them that they will not be in the nurse home visiting program, and yes, we were told that we cannot refer them to another home visiting program in the community because that will affect the study. We send them information on the different prenatal providers in the community, week information. We have Text for Baby here where they can get regular text messages on how to be healthy during pregnancy. And we give them the 211 telephone number and the different welfare offices where they can apply for Medicaid and assistance.
And one of the issues in Nevada is that there was another MIHOPE study site there, so they couldn't be referred to another program that's also participating in the study. So.
Okay, next question. How will the researchers account for confounding factors such as control group clients being in other evidence-based programs?
Hi, this is Ginger. Let's see, confounding, there's sort of two questions embedded in that. One is generally confounding factors, and to a great degree, a random assignment study actually controls for the vast majority of confounding factors that you would normally worry about. That's really the purpose of having a comparison group to compare the outcomes to. It's specifically, though, about what happens when the control group receives other services in the community. I think the way to think about it is this is really a study of whether NFP and HFA services lead to better outcomes over and above what else is normally available in the community. And so it's not a comparison to clients receiving no other services. It's a comparison of, does this set of programs, this set of evidence-based home visiting programs lead to even better outcomes than whatever other services clients might have found on their own. So in reporting on the impact results, it's true that some comparison group members will have gotten other services which might factor into the outcomes that they have. But so that's the way to think about the impact we're measuring.
Okay, great. Next question. For NFP sites, would clients that are referred into NFP and declined services be eligible to participate as a non-assignment control?
Do you mean refuse services?
Yes.
Oh, so you're asking whether someone who does not want to be in the does not want to get services, could they just help by being in the comparison group? The answer to that is no, because we really need the program group and the comparison group to be similar in every way, including how motivated they are to find services. So if we allowed the program group to be mostly people who were interested in the program and the comparison group to be a lot of people who actually said, no, I don't want to be in the program, it would turn out that those two groups are actually quite different from each other in a lot of ways. And so we have to only include people who do show some interest in the NFP program.
Okay, great. Okay, the next question. We are concerned that the intake process will take longer because of the introduction of MIHOPE-Strong Start, and we will miss the window for enrollment into NFP. Can you address that?
The way I understood it is, this is Teresa, is that when we get our referrals, we call the client, and then we set up an appointment to meet with them and explain the study, and so they can either say yes or no, and if they said yes, of course, we can get them to sign the consent. And that's all we do for that part. And then we inform the MIHOPE study that this client consented to the study, and they will do the random assignment. If they are selected to be in the home visiting group, and that's the only time that we can enroll them in the NFP program.
And so in terms of the timing, the random assignment happens immediately for MIHOPE-Strong Start, either right at the time when even when you're still with the client, or if you prefer, it could happen overnight so that you get notification the next day. It depends on the program. But so the process should actually not slow down enrolling people into the program very much. And we have a rule that if it takes too many days to find the person and to tell them about the study, at some point, I think it's a 2-week cutoff. We just do not keep trying to enroll them into the study. They go ahead and are randomly assigned either into getting your program or not getting your program, because we don't want the study to slow down your process. If someone is very, very near the cutoff for gestational, time, you can prioritize that client and, speed up the process so that they come in as quickly as possible. It really shouldn't slow them down very much.
One of the things that's asked, I think Teresa mentioned putting clients into the intake system. One of the questions that's asked is the due date, and it's actually the computer's tracking that. And so if someone is getting close to the cutoff, the system would warn you and wouldn't wait the full 2 weeks that Ginger mentioned. So we wouldn't allow the system wouldn't allow someone to click over into not being eligible
without. Sharon, I just want to remind everybody that each site, like us with the MIHOPE, we have like 3 exempt space. Like, for example, if somebody is really, really very close, then we put that client in the exempt group.
Oh, that's a good point, Teresa. Thank you. So for MIHOPE-Strong Start, we would actually give you 5% of, so say you're going to enroll 100 people into the study over the time period, you would have 5 free exemptions. It's 5% of whatever number you agree to do. So that if you have people who are either, like you're saying, if you want to use one on someone who is just very, very close to their due date, that would be okay. But you can also use them for people who have some really dire circumstance where you just really, really do not want them to go through random assignment. You can use one of those exemptions for that person. And that's just your decision. It's just, you know, it's totally your call on who those should be used on.
And this is Margarita, and we valued that because we were able to use that for MIHOPE for some really high-risk young ladies, and we were able to enroll them in our program. And as far as our experience in MIHOPE, I don't think we had too much of a delay in individuals getting randomized, but it sounds like the Strong Start is going to be done much more quickly. And again, one of the key things was the fact that Teresa, jumped right on those referrals. She was very efficient.
Okay, the next question, does the client get a choice if she doesn't want to be in the study up front? Can she refuse the study and be enrolled in NFP?
She can refuse the study. So the two decisions are separate from each other. So someone who is found eligible for NFP and wants to be in the program, the next step is, if they're eligible for the study, they actually are presented information about the study. If they don't want to be in the study, they're actually still randomized to either being in the program or not being in the program. The reason is that we did not want, whether someone agrees to be in the study, to change their chances of getting program services. So we didn't want it to be that if you agree to be in the study, that makes you more likely to get our program, because we the study has to be completely voluntary for people and not affect their program chances. We also didn't want it to be if they turn down the study that they would automatically get program services, because then we'd have a lot of people turning down the study and we wouldn't have a study anymore. And so we decided to keep them separate. And if your site agrees to be in the study, what you're agreeing to is that you're willing to allocate your program slots for people who are eligible for the study. You're agreeing to decide on whether they get the program using a random assignment process. Then the client gets a choice whether they want to be in the study and have the data collected about them that we need in order to conduct the study, and they are volunteering whether or not they're willing to have the data collected about them.
Yes, and with our experience, this is Teresa again, yes, even the ones that didn't want to be part of the study, and then when you look at the web-based intake, they get randomized to home visiting or non-home visiting, and it will just indicate to you that if they're part of the study or not. So if they are selected in the home visiting group, not part of the study, so we just enroll them, just like our regular NFP clients. And then you can say, like, the non-home visiting group, not part of the study, so we don't have to do anything about those clients.
So
except for sending them the letter.
This whole, the whole way this flow works, and sort of a little tree of sort of what happens to people if they say yes to this and no to this, we walk through that very carefully with you as we talk through how this will all work, so that anyone who's coming in contact with the, people at the early stage of this really, really will understand how this flow will work.
Okay, then there's a related question about what happens if a client finds out that she was not randomized to the home visiting services and she wants to decline from the comparison group. Can she request to sign up with NFP services again?
No, if your site has agreed to be in the study, once someone is assigned to the comparison group, they're in the comparison group until their child is 1 year old. So they can't go, oh shoot, I didn't want to, I wanted program services, I'm dropping out of the study and I'm going to re-enroll in the program. By being in the study, you're agreeing that that person will not get your services if they've been put in the comparison group.
Okay, great. Next question. Did your nurses have to adjust their caseloads to compensate for time spent enrolling clients into the study?
No, we don't have to adjust our caseload. We follow the program fidelity that they can carry, 25 caseload. We didn't have to do anything about it. It just, we just put a more time and effort to be able to recruit those 60 clients in the program.
It really, because the MIHOPE requirements have really not been cumbersome at all to our staff, as in comparison to the requirements for the MUCV for our state. So no, it really has not made a difference at all in the way they operate or their caseloads or the amount of time that they have had to put into their cases.
All right, next question. We are worried about long-term effects on our relationship with referral agencies if they don't agree with randomization. Are there best practices to deal with this concern, or do you have other suggestions?
Well, so I can start, and Sharon, if you want to jump in. I mean, I think we basically do offer to either talk to them directly with you or offer you sort of talking points that help to convey why the study is important. And what we're really trying to do is help them see the long view, that the study really might help in the long run. A lot of funding for social programs these days comes with, evaluations, and it really does help bolster the case for future funding. And so we try to really have them understand why it's an important study, so that we're not just saying we're doing it, that's the end of it. We really try to get them on board so that they end up, happy that they're able to be part of it. And we have some resources as well. We have things like press releases you can use in your local area, or talking points. We also have another video that is geared towards the referral process. It's actually aimed at, you being able to use it with a local recruitment partner to help explain why you're part of the study and why the recruitment is such an important part of the process. So there are a variety of ways we try to get across why it's important to keep the recruitment flow going.
And we did have some concerns from our major referral sources, as well as some individuals in our administration about the randomization. But once again, we received an awful lot of support from the MIHOPE team. As I said before, we were able to arrange for a teleconference during an advisory board meeting where most of our referral sources sit, their advisory board members. They had their questions answered. And in the long run, it's still our belief that we think participation in this is so very valuable, because we want to be able to sustain and expand these very valuable home visiting programs.
And in reality, anyway, not all the referrals that they send us are able to receive nurse-family partnership program. Sometimes we get the referral, and then when you contact the client, they don't want to be in the program anymore. They change their mind, or maybe we cannot locate them anymore because of their telephone numbers and addresses. So not really 100% of the clients that they refer to us receive nurse-family partnership program.
And we have the same issue if they reside outside of one of our target zip codes. We may not be able to serve them anyway. I mean, if it's someone that we feel is critical that they receive services, we might make an exception, outside of participating in the study. but we still cannot serve everybody that gets referred to our program.
Great. Next question. Will some NFP participants currently involved in MIHOPE be able to answer some additional questions about their experience by phone or email after the webinar?
I think this is Sharon speaking. We do have other programs that are in MIHOPE that, we prefer them not to be inundated with phone calls, but yes, there are others that could respond as well. So for those of you who've had some contact with us, or you may hear from us shortly, the team that reaches out to you, if you just ask them questions like this, then we'll try and arrange something centrally so that you can speak directly with some of them.
Okay, next question. Are you looking for programs with a minimum number of potential new enrollments within the next year?
Well, our preference is for larger programs, in part because of the sample size we're trying to reach, and so this is different than with MIHOPE, where we asked each program to enroll 60 families in the study. We're asking for larger numbers than that, and so we haven't really set a caseload size. We're really looking at the number of home visitors, and so I think if a program has fewer than 3, that they're pretty much too small. 3 and up are the ones that we're reaching out to and are speaking with.
Okay, so we've got several. David, this one is directed towards you specifically, and others might want to respond as well. But we've gotten several comments and questions about attendees feeling uncomfortable turning families away from the program, given what they know about the impacts it makes in other people's lives. And so we're wondering if you can address that and talk about how that intersects with the importance of the study and what will be produced out of it.
So can I take that?
Yes,
can you hear me? This is David.
Yes.
I think that so much of this depends on the extent to which the demand for the program exceeds your capacity to serve them well. If you're serving virtually all of the families who would be eligible for the program in your community, it would be unethical to turn them away, given the knowledge that we have available. But if you are unable, or you have more families who are eligible in your community than you're able to serve, that shifts the ethics of this considerably, because there are so many additional benefits produced for society as a whole in learning how to serve families well, and particularly how to the extent to which the program prevents prematurity and low birth weight. So I think it boils down to that and that issue. And one of the things that I'm seeing is that MDRC is able to work with local communities to brainstorm and help develop referral sources and to transform referrals into enrollments. So the experience in Nevada suggests that it's not really produced diminished services for families and communities. And in fact, if I may be inferring here, but it looks like there is, once those referral systems are built, your capacity to reach larger segments of the population in your community are going to be enhanced once the study is done. I don't want to overstate that, but I think that's a reasonable possibility based on what I heard Margarita and Teresa say.
I think that's true, David. I mean, one of our goals in any of these kinds of studies is that we sort of, in working with local sites, we make sure they have a good enough experience that they would want to do another study someday. And so that's sort of our standard for how we work with folks, is that we want them to have a good experience. And we often do find that local programs in one way or another have some kind of increased capacity, especially on the enrollment and recruitment side, once they've been in one of these studies, because it really does have people kind of tightening up their processes, thinking about new partners, bolstering their existing partnerships by really paying close attention to them. And it actually does often end up with that process just feeling a bit stronger by the end.
Right, and we generally hope that this isn't the case everywhere, that programs need assistance with bolstering their referrals. But if we can provide some assistance there, actually what the program is doing is reaching out to sometimes communities or pockets that wouldn't otherwise have heard about the program because you might have been already filling your slots. As Teresa was saying, with particular zip codes or whatever, but now you're reaching to a larger community. So these are people that are aware of the availability of services that they might not otherwise have learned about.
Okay. Just want to give the panelists one last opportunity if there's anything else you want to add.
This is David. I just want to say that it really, from where I sit, I think these are wonderful questions. I think that the issues raised reflect a level of caring and thoughtfulness that is really wonderful, and it's been really great being part of this process with you.
Well, thank you, everyone. I know we're at our point in time. We know you all have other meetings and conversations to have, so we apologize that we weren't able to get to all of the questions, but we will pull those down and bring those to our future discussions with you all. Again, thank you to all of the panelists and the attendees for participating today, and we look forward to speaking with you in the future. And one last note that, the webinar will be archived. It will be up on our website, and Molly will be sending that through the NFP National Service Office listserv. So you all will be receiving a link to the archived video. Thank you again. Have a good day.